So, welcome to the Access Policies webinar. As ever, we'll be using the Menti system to collect your feedback throughout the webinar. So those of you that are familiar with our webinars will recognise the QR code there, but if it's the first time you've joined, and we know from our feedback that a number of you do join for the first time each time, then please use your smartphone to scan the QR code thing on the screen, which should take you to the Menti website, or you can go directly to the Menti website on your computer or on your phone and put in the code written at the bottom there, which is 3602854, and that's menti.com. The code will be visible on the slides throughout the presentation, and there'll be a few more flashes up of the QR code as we're going along so that you can join in the fun. So the purpose of today's webinar is to give you an overview of what we mean by access, why an access policy is important, and why improving access is important, what are the barriers to getting access right, and what are the consequences if you don't. We want to get you started in how you can write your own access policy, and also share some experience of people who've written an access policy and to learn from some of the kind of pitfalls and so on that they've encountered along the way. We're going to talk to you a bit about using data to inform the need that will underpin your access policy, and we'll talk to you about what's important in terms of measurement and review and knowing whether or not your access policy is effective. As ever, we're going to be using the chat function in Teams to collect your questions as we're going along. So unless there's something particularly time sensitive, we won't take questions as we're going along, but my colleagues will collate all the questions from the chat Q&A bit as we're going along, and then there'll be a Q&A session towards the end of the webinar where we'll all answer your questions as best we can. And if we have time, we might well bring you onto camera or mic if you feel comfortable doing that in order to ask your questions and to interact with our speakers. So please do put your questions in the Q&A box. We're always learning as we go through these webinars. We're always trying to improve the materials that we've got on our futures site. And I would encourage you to access our futures page. The link is here and on various other bits scattered around the presentation. For those of you that are not registered already, please do register on our futures site. You'll find all of the webinars we've already done, the slides, the recordings, and the resources, the checklists and so on that we flag as we're going through this series are made available to you, obviously for free. Next slide, please. So who are we? We are the Mental Health Intensive Support Team, for those of you that have not joined the webinar before, who haven't encountered us out in the wild. So we're a small expert improvement team. We're a group of senior managers and clinicians, and we support the NHS free at the point of use to deliver improvements in population health, quality of care, and value for money in mental health care and learning disabilities and autism. We've got quite a mix in our multidisciplinary team. We've got senior experience of operationally delivering mental health services and service improvement generally. We've got a significant amount of knowledge of the design, delivery and waiting time standards, and also the majority of our team are also professional registrants. We've got experience of acting as clinical leaders and an expert clinical resource. We've got a range of backgrounds across kind of general improvement, data management, governance, operational processes, and clinical experience, as I mentioned. And we're here to try to help systems to improve the timeliness, safety, equity, quality, effectiveness, and patient-centeredness, if that's a word, of their care delivery. Next slide, please. So this is part of, in fact, the penultimate installation of the elective programme for elective recovery for mental health. And we developed this programme of resources based on our experience from doing 5, 6, even 7 years of diagnostic reviews across a range of mental health specialisms, including EIP, Children and Young People's Mental Health, IAPT, or the office formerly known as IAPT, and other parts of the mental health landscape. And we've used all of that learning plus experience from our colleagues in the physical health intensive support team to bring together a programme of elective recovery resources to try and help you as providers and as commissioners and as systems generally to make the most of what you have available to you coming out of COVID and in the generally straitened times in which we find ourselves. Next slide, please. As I mentioned, this is the penultimate instalment of the Mental Health Elective Recovery Support Programme. So we've already had modules on waiting lists, on optimising capacity, on pathway mapping, patient tracking and improving flow. This is the module on access policy, and we've got commissioning to optimise delivery coming up in about 3 weeks' time. The details of all the previous webinars, as I said, and their recordings are available on our futures site, And towards the end of this presentation, we'll also give you details of how you can register for the commissioning webinar, which is coming up. Next slide, please. So finally, we will give you information towards the end of this webinar about how you can give us feedback on this one, but we're really keen to hear from you and to get your feedback so that we can improve our webinars in the future and also improve the resources on our futures site. So what we heard in the feedback from our most recent webinars was that everybody said that the webinar had improved their understanding, which is really encouraging, and improved their confidence. So it's quite good to hear that we're doing something right and that you are benefiting from what we're doing, but we always want to know what we can do better. And certainly what we heard loud and clear from the previous one on patient tracking was that a clear introduction to the subject matter and kind of back to basics was required at the beginning, because some attendees had little or no knowledge about the subject prior to the webinar. And certainly we're very mindful that we've got a range of levels of understanding, and we will try our best to make sure we cover the introduction as well as some of the more advanced subject matter, if you like. And finally, in terms of what people wanted more of, we want more examples from providers that have already implemented some of the tools and techniques covered. And certainly in this webinar, we'll be hearing from a couple of systems about what their experience was in terms of implementing an access policy, as well as some broader experience from the land of commissioning about what it is to implement access policies. So without further ado, I'm going to hand over to my colleague Sarah, who's going to take you into this webinar about access policies.
Thank you, Michael, and good morning, everyone. Thank you for joining our webinar today. My name is Sarah Brennan. I'm one of the improvement advisors with the Mental Health Improvement Support Team. I am a registered mental health nurse by my background, and before joining the team 6 years ago, I worked solely within provider organisations, undertaking a number of different senior clinical and operational roles. Next slide, please. So I wanted to start today by just giving an overview of what we mean by access. A key principle of the NHS Constitution is patients receive timely, equitable access to treatment, and as such, access standards are an important organising component for us in terms of measuring how long people wait to access services. And this is now seen as a fundamental element of assessing quality of care and patient experience. Access standards are underpinned by a number of principles and rules that support delivery of services, and as such, there needs to be a clear awareness and understanding of these principles and rules across all stakeholders and the system landscape. So today's webinar will provide opportunity for us to think about access and why it's important, and also give us opportunity to consider how to provide a delivery framework in the form of an overarching access policy. So whilst access policies in acute and hospital services are widely recognised as key to providing that guidance on referral, treatment and waiting time management, they are actually less recognised within the mental health sector. So the reason for this is unclear, but we could assume that there has been less focus on the 18-week referral to treatment standard, and that there are generally fewer national waiting standards in mental health, making the need for an access policy a little bit less obvious. However, with the long-term plan for mental health, we are seeing an increasing number of new waiting standards coming through. So, for example, in community children and young people and adult community mental health services. Therefore, having an overarching access policy is probably now more important than ever. However, I think introducing an overarching access policy could represent a significant shift for staff delivering services, and as such, it's important to first understand the drivers and the reasons to why it's so important. So I'm going to hand over now to Simon, my colleague, who will give an overview of some of those drivers and the reasons of why that is so important. So over to you, Simon.
Thank you very much, Sarah. Good morning, everybody. My name is Simon Bristow. I'm also a mental health nurse by trade, and prior to joining the team, getting on for about 4 years ago now, I also spent the best part of a couple of decades doing lots of different things in providers. So promoting equality, diversity and inclusion is a public service duty. So all publicly funded bodies are responsible for promoting these. And there are three things that need to be considered when thinking about health inequalities, and they are protected characteristics, deprivation, and access. So the NHS has very limited ability to impact who in the population will have protected characteristics, and very little ability to impact on deprivation and the deprivation variance within the communities that we serve. However, we do have considerable impact in terms of how we can support people to access the health services that we are employed to deliver. Could I have the next slide, please? So if we deploy a service in a society where there are existing health inequalities, if we don't specifically plan in advance for how we're going to reach out to the currently excluded groups, then we reinforce those health inequalities and also risk introducing new ones. So when we think about increasing access, what needs to be at the forefront of our minds is ensuring that there's equitable access to the resources that are available, and that we are proactively reducing the numbers of people in marginalised groups who are currently directly or indirectly excluded from the service. So to develop an access policy, you'll need to understand what support different groups in your area will need to be able in order to be able to be aware of the service, to feel comfortable using it, and to be able to practically access it. So to give a simplified example, if you deploy a service in a deprived area where there's a requirement for patients to book into clinics solely via the internet, then anyone who's living in digital poverty and doesn't have access to the internet is subject to a de facto exclusion from the service. So a key exam question for any access improvement work is, does this service deliver more equitable access for all members of the community? And in order to answer this question, it's important there's a collective understanding of who the excluded groups are within your local communities and what barriers they face to accessing treatment. So we strongly recommend that commissioners and providers of services follow these 3 steps. Firstly, use local population data, for example, from your JSNA, and there are other population analyses as well, to understand how different groups are represented within your local population. Secondly, compare that to local data on which groups are and aren't accessing your services and in what quantity. So this should include routes of access for different groups. So for example, if you've got a specific group that's overrepresented in presentations via crisis services, but underrepresented in presentations early intervention services, like the service formerly known as IAPT, then even though they may be accessing services, you have an access issue for this group, as they're not presenting until they are severely ill. This will enable you to understand what the gap is between who you'd be expecting to see in your service and in what quantity, against who you are actually seeing in your service and in what quantity. So thirdly, once you understand that baseline position, you can use the Public Health England developed health equity assessment tool to develop targeted interventions for how you're going to reach the currently excluded groups, and plan how you're going to measure whether or not the access policy is supporting improved access for the excluded groups that you have identified. There's lots of further guidance on planning equity and mental health service delivery that we'll be revisiting, and we'll be revisiting this theme within our Commissioning to Optimise delivery webinar coming up on the 21st of February. There's also an excellent comprehensive how-to guide that's been produced by the Royal College called Advancing Mental Health Equality that we would highly recommend, and is linked to here. Could I have the next slide, please? So our first mentee of the session, for those of you who have joined before, you know that we are big fans of the mentee. If you had joined after Michael's helpful introduction to how this works, if you have a smartphone to hand, please use it now to scan the QR code on your screen, and it will take you to a web page in which you can enter data that is interactive for this webinar. If you do not have a smartphone to hand, you can go to menti.com and enter the code on the screen, and that will also enable you to access not just this question, but the rest of the questions that are going to be coming up through the webinar. So could I have the next slide, please? Okay, so first question of the day, we're going to have a word cloud, and can you tell us about some of the barriers to access within your services? So you should have 3 options here. Yep, geography. Definitely a different challenge in urban areas than it is in rural areas, and some of our organisations cover incredibly large patches, varying levels of infrastructure. Yep, lots of it was a movement on the screen: deprivation, transport, literacy. lack of public transport options, disabilities, interpreters, acuity, exclusion criteria. Often, yes, there's a lot clearer about who's not eligible to access a service than it is about who is eligible to access a service. Yeah, digital poverty, definitely an increasing challenge. That's really rich and helpful feedback. Thank you. This is stuff I think we'll take this away and have a think about this in relation to the guidance that we've got on our future NHS platform. That's really helpful. Thank you. Could I have the next slide, please? So we've got a pre-populated list of some of the common barriers that we have come across. And the health inequalities is only one of the barriers that people may face in terms of accessing services. However, many of these common barriers also increase health inequalities in a sort of unvirtuous circle. And the institution of constitutional standards for access were developed to try and support systematic approaches to thinking about access. So, for example, it defined rules about how to measure access and how long patients wait for treatment and how to manage waiting lists, etc. So again, one of the key kind of exam questions we need to ask ourselves is what can we do practically, operationally, to reduce barriers to access and improve quality and experience for each of the different subsets of the population using our services? So well-constructed access policy is the vehicle to answer this question because it gives clarity to staff and patients about the operational activity that will be undertaken that's going to improve access. So, for example, there'll need to be a section in the policy that explains what the constitutional rules and standards are and the steps that will be taken to ensure that they are delivered, i.e. patients will be seen in order of clinical priority and then subject to chronological order in terms of how long they've been waiting. So adapting how we deliver services is possible in relation to all of the barriers that are shown in this diagram, and some of these are entirely within our control. So to give an example, the mental health landscape often feels like an opaque and confusing maze, even to people who are actively seeking support. So for individuals in marginalised communities who may not have access to the routes by which we passively advertise service directories, such as trust websites, it's unlikely that they're going to know what's available and how to get there. Historically, a number of patients have been categorised as hard to reach, but the challenge that we are all putting back to ourselves is how can we say that this group is hard to reach when we haven't gone to where they are to reach them? As ultimately, as a public body, it's our responsibility to tailor services to meet the needs of the population, rather than the population's responsibility to access information in a way that's most convenient for us. Limited modes of access is also a key consideration, as this is something that's often we're not able to do optimally. So services need to be accessible to the community, including all members of the community, including those with protected characteristics. An example of getting this wrong would be providing a service like a mental health crisis line that's only accessible via telephone, as this would obviously exclude deaf members of the community from being able to access support. So again, the Public Health England HEAT tool is the vehicle for you to think about what actions you might take in order to address these so that you meet the needs of the whole population. And at this point, I'll pause and hand over to my colleague, Maureen.
Thank you very much, Simon. Good morning, everyone. So my name is Maureen, and I am coming in with a CAMHS background. I thought that I would bring the parent carer service user a viewpoint into our session this morning. And in front of us, we have some quotes that we've collected from parents sharing their experience of accessing our services. So here we read, social care were not willing to get involved, and consequently we couldn't access other services. Fight, fight, fight. That's all we have been doing. Where there is no transparency, there are usually no services. And lastly, I need someone to help me to support my child when I don't know or lack confidence. Next slide, please. Thank you. So just to summarize, really, the parent carer voice, the request or the strongest ask is that they are involved in our shaping of our policies. So how are we including family feedback into the work that we're shaping? So are we including them in our governance structures or in our boards, making sure that there's representation on our boards, and also consider co-producing front-facing materials which will help families to signpost and just make it clearer for them as to what the policy is. There's an NHS England initiative called Ask, Listen, Do, and so it's not just about the asking and refining, but it's also about listening, really listening to how the patient's experiences and what changes need to be made, and then the third part about doing. And also what they really want us to change is considering the multi-agency approach. So a lot of feedback about gaps in knowledge and gaps in service, for example, within primary care, eating disorders, learning disabilities, autism, looked after children, that perhaps we could strengthen the access and the understanding for those cohorts of patients, and making sure that we're really considering how we are streamlining our services so that it's a coherent policy. And lastly, what I'd like to highlight is the offer for children with SEND, that this is actually enshrined in law, and it is a request that every local authority has the local offer described on their websites, and then thinking about mental health access and what is written in those local offers, whether you are contributing to that and making that clearer. And as I've said, just making sure that we are including everyone, include your voluntary sector organisations, because they hold a lot of information. Parents often attend and engage with them as a first point of call, so they have rich information and can help shape and influence our work. Thank you very much for listening to me. I am handing over to my colleague Sean.
Hi everyone, my name's Sean Griffiths. I'm a mental health improvement senior manager within the team, and my background is mental health nursing as well. I'm also with my colleague today, Matt.
Hi everyone, I'm Matt Wickenden, and my pronouns are he and him, and I'm a program manager in the mental health policy team leading on data and reporting development.
Firstly, we're going to have a couple of Menti questions. So, how often are you using data to measure equality among people accessing your services? This is a multiple choice question who wanted to put in how they're accessing services at the moment. Okay, so we can see weekly coming out the most, monthly as well. Okay. So we can see that most of the people are doing it monthly, and I suppose that kind of coincides with submissions as well. I'll just give it a few more seconds to if anyone else wants to answer, but we can see that monthly is by far and away the most popular choice there. And the next question is a word cloud. So, what are the barriers to routinely using data to measure equality in patient access and care quality? So this one will be a word cloud, and we've got a minute. So if we wanted to start putting in what they see as their barriers. Incomplete data, that's something that we're going to kind of talk about in the slides that we've got. Yeah, we see that's another one, around completeness of data accuracy. So we can see that obviously that's a big issue, that if we can't get high quality data, then some people can see it's not worth using. Quality of data inputted, MHSTS data, gaps in data, capacity. We can see at the moment people's capacity is stretched, so this may be something that's pushed down. Time, reliability, finding the data as well. So if we can't get good collection points, then that could be an issue as well. Timeliness, so if we're using old data, then that might be a barrier as well to using it. MHSTS data in ICBs, to see that as well. Data collection systems, so if it's a cumbersome manual process, then people are less likely to be using that. Okay, so that's pretty much done now, and we'll move on to the slides that we've got. And the first slide is around using data to improve access. So one of the essential parts of developing access policy is understanding who's accessing services and who is not accessing services. So if you fully want to understand the current and potential health inequalities, data around these is key. With the correct data, you should be able to understand what people access your services and the representative demographics and characteristics, and if this matches your population that you serve. And we also can identify if there's any particular patient groups that are under or overrepresented within your services. And we can also see if there's any health inequalities that adversely affect population that you serve. And it's also important that we understand the demographics and characteristics of the staff group as well, to see if this matches the population. So we also need to think about when we're collecting data that we're not just the hard data, but also soft data around feedback, so we can get feedback around the access to services, the barriers that people may experience. So you might not see that in the data, but if we engage with people like patient groups, and you can find out some more of that. At the moment, nationally, these products are steadily improving, and there's more products coming online, and that's something that's being done over the next couple of years. So over the next couple of slides, we'll be talking about some of the data quality issues that we have, and also some of the different sources that you can access data through. And next slide, please.
Okay, thanks, Sean. So we'll give you, as he says, a bit of a kind of quick run through. We won't be able to go into the sort of full picture these give you, but hopefully give you enough of a sense of what's in there to pique your interest. So NHS Digital have produced a range of publicly available data quality dashboards across the MHSDS and the IAP dataset, and I'm sure there's some others like the community dataset you can access data for. So an example here is the data quality dashboard that lets you see an overview of the different data completeness of the various protected characteristics and other vulnerable groups. And something that's really important to bear in mind is yes, there are a range of characteristics that have low completeness, like sexuality and accommodation status, but actually age is a really significant inequality issue, with older adults experiencing some quite considerable access and outcome issues and so on. So there is data that we can all be focused on right now, but also we need to be thinking about that whole process of data collection from a patient and service perspective to really think about, are we providing inclusive environments that make people feel safe to share information, as well as the kind of technical setup of our systems and whether they allow people to capture information easily. So yeah, the data quality dashboard gives you that summary, and there's also trend information, so you can see, is my data improving or going down over time at a provider level, as well as across systems nationally and so on. Next slide, please, Sean. Are you frozen, Sean? I may have lost my colleague, possibly. Oh. No, you're back.
Okay. The next slide we're going to talk about is one of the sources, the first source, the model mental health system. So for all sources we're going to talk about, there'll be a link at the bottom of the slide. So if you catch up with the slides later and you can get them off our Futures platform, then you'll be able to access the sources. As Matt was saying, with age is something that's used quite prevalently, and the way you can cut the data within the model health system. But the model health system, as you can see from here, has ethnicity data you can cut from mainly across caseloads, so the community caseloads used by ethnicity, age and gender. But you can break this down also for crisis caseloads, so you can see how people are accessing your services. If you've got high crisis caseloads and low community, certain demographics, it may indicate that people are unable to access services through their usual routes. You can also have inpatient data as well on the model health system, and this can be broken down with age and gender, so you can see if there's any disproportionate groups that are being admitted into a hospital, or age ranges that are being admitted disproportionately, and to different bed types as well. And next slide, please.
So I'll take you through some examples of other reports that are publicly available. So the fingertips profiles that some of you may be familiar with were produced by Public Health England. That's now the Office of Health Improvement and Disparities. And what the profiles do is give you more of a population health management focus on mental health activity, and measures such as excess mortality for people with SMI. There's 3 mental health activity focused measures that include referrals and attended contacts to community services, as well as inpatient stays. And just an example of what those let you pick out down to CCG level, because generally we need annual data for quality, and at the moment the most recent year we have is pre the new NHS boundaries. But what that data shows is on that bottom right chart that as I flagged that older adults issue, there is what appears to be declining rates of new referrals and attended contacts for people aged 65 plus. So this data already lets us kind of query, are we, with the investment and transformation happening in mental health services, potentially leaving behind those older adults in our services and not giving them the support and access they need. Next slide, please. So then there's the Mental Health Core Data Pack, which again, some of you may be familiar with. This is NHS management information produced by NHS England. So this sits on the Future Collaboration site and summarises performance across long-term plan metrics and other sort of priority national measures. And it does include 4 equality-focused measures for NHS talking therapies for anxiety and depression / what was IAPT, as well as admissions, adult acute admissions with no contact with the mental health service in the year before, and long lengths of stay for adults and older adults. So for the example shown in that chart below, is it does let you compare across areas at ICB level to see how does our area compare to others on those measures, and give you a sense of are there opportunities to improve. Next slide, please. And then another one that's publicly available is the Mental Health Bulletin Dashboard, produced by NHS Digital, and there's also the Mental Health Act dashboard that you may be familiar with, and an IACT one. So those annual reports all give quite a range of equality measures, and particularly in the Mental Health Bulletin Dashboard, we've really increased the range of information in there. So you've got on the bottom left, the variation in adult acute admissions with no contact with services by ethnicity, and then on the bottom right, the variation in access to community services by ethnicity. And you can see really significant variation. This data here is at STP level, so just showing that it can be used at that level, and picks out some important issues to think about in the sort of pathways available to patients. Next slide, please.
And lastly, we've just got some data with access on learning disabilities. So I wanted to include this because obviously some of these providers will provide learning disabilities as well as mental health services. So on the left-hand side, you've got the autism waiting time statistics publication. This is through MHSDS data, and you can cut here the statistics through through gender and ethnicity breakdowns, as well as age. These provider and ICB level. At the moment, the interactive dashboard doesn't have the ethnicity breakdowns in, so you'd have to access the data through there. But it is on. You can access it through the link here. And the second is on the autism health inequalities dashboard, which is on the right. This is some of the data is caveat with this that some of the data is like 2020, 2021, and also there is some variation in the data quality. So it's the uptake of it. So some of it is more usable than others, but you can look at things on there like breast screening uptake, prescribing certain medications, and you can break that down within your area and compare it to the national average for benchmarking purposes. I'll be handing over now to my colleague Sarah.
Thank you, Sean, and thanks, Matt. So this section will focus on the nuts and bolts of writing an access policy. So from why it matters, what to include when developing yours, and who to involve in its development. Next slide, please. So we touched upon why having an access policy matters in the introduction section of the webinar, but it's really important to reiterate those key principle drivers to why it matters so much. So if we start from the point of what an access policy should be, an access policy should describe the way in which an organisation manages patient referrals, waiting lists, appointments and discharges. So the overarching principle is that patients receive timely care in clinical priority order. Therefore, the policy should state the arrangements for that management of the processes, and as such will have some core functions, these being to set out the principles and rules for managing patients through their mental health elective care pathway. It should include the guidelines and the procedures that relate to this to ensure that waiting lists are managed effectively whilst maintaining that high quality of service to patients. It should be designed and written in such a way to ensure the management of access to planned mental health services is transparent, fair, equitable, and managed in order to those sort of clinical priorities. And the policy needs to be applicable and understandable to all clinical and administrative staff delivering the services within the organisation. So the aim, therefore, would be to provide a policy framework where all the rules, the key principles, expected milestones from entry through to discharge sit. And the accessible information standard is also important here. It's an important consideration as it requires the NHS providers to ensure that the information provided is accurate and accessible, and that there is a promotion and awareness of the services provided within the community the organisation serves. Next slide, please, which I believe is a Menti question, and the first of this section, and it's a straightforward Menti question. So, does your organisation have an overarching access policy? And it's a yes or a no. It's great to see that we've got 5 yeses. That's 9. Amazing. 12. That's brilliant. So that's definitely an improvement on what our experience has been previously. We've got some don't knows and we've got some no's, but actually, which is really good news, we are winning out on 14 yeses. That's great. Okay, I think we've stabilised at 14, 5 and 10. Okay, thank you. So why is it important? We need to consider why having an overarching access policy is important in terms of how it supports improved experience, access and delivery of services. It could be argued that to support such improvements, it should be seen as more than just a dry document providing operational guidance. It could be seen and should be seen as a live document actualising those key principles of why timely access to the right care is so important. So put simply, we know that people with mental health conditions that are seen more quickly by the right people have better outcomes than those experiencing long treatment delays. We also know from feedback from patients that people with mental health conditions want and deserve timely access to treatment, and having clear guidance and procedures on this would support that. We know from feedback from staff want to give people the best treatment in a timely way, and having access to an easily understandable policy that helps them navigate all those interrelated processes supports them in doing this. So we have now put in simple terms the importance of the policy, and now what we hope to do is cover what it should actually do. In terms of how it should work to support staff, it should be seen as the operationalising or the coming together of all the different pieces that contribute to the whole service, providing good access to assessing needs and providing treatment. The policy should provide staff and others reading it with a how-to roadmap for managing entry to services, managing waits, flow and discharge processes. It needs to be user-friendly to all, regardless of role, so thought needs to be given to this and how to achieve this. This is where a collaborative development approach is really important, as this will give and support diversity of ideas, which can be really helpful for all policies. The policy should also inform patients, relatives and staff of their rights and what to expect from the provider in terms of access. So someone said to me during the development of this webinar that an access policy feels like the putting together of a jigsaw puzzle. You only actually see the whole picture once the pieces are connected and complete. And that is exactly it, actually, the case, and it's exactly the case as it ensures all the different processes knit together so they don't feel like disparate or unrelated parts. So in terms of our other parts of the webinar series, you can see how the other modules we've delivered relate and would support the development of your policy. So for example, having guidance on how to manage backlogs, patient tracking lists, understanding flow, these are all essential elements of what the policy should include. Later on in the webinar, what we will also cover is our access policy checklist, which provides a step-by-step how-to guide to support you in your policy development. Next slide, please. Next slide, please. So there are some essential elements that need to be included in an access policy. So to start with, the policy needs to provide an introduction to the overarching principles and state the commitment to patients. It should include details on how it was developed and with whom, and the details of its purpose. The purpose section should state why the policy has been written, making reference to the NHS Constitution and the national waiting time standards. Other essential elements need to include a section on the responsibilities, accountabilities and duties. This section should describe specific responsibilities of key staff and groups of staff within that. So two examples could be, it could be a divisional general manager is accountable for the implementing, monitoring and ensuring compliance to the policy, or from a team perspective, the BI team, the business intelligence team, is responsible for producing and maintaining regular reports to ensure services to accurately manage their pathways. This section is often overlooked, actually, but a critical, important section. It can sometimes be assumed that all people are very clear on their roles and responsibilities for managing waiting times and standards. However, given some of the current workforce challenges and the potential for fluidity in roles and responsibilities, some staff may not be explicitly clear on this. Also to consider is that good practice determines that there's a clear distinction drawn between the roles of staff responsible for meeting and delivering the standards and those responsible for reporting on performance. Therefore, clear reference to the responsibilities and the governance structure for reporting and escalating should therefore also be included here. Reference to staff competencies and compliance is also important, and there needs to be a section which covers how staff will be supported to demonstrate their competency and compliance to the different elements of the policy. So, for example, details are required on training to support those capabilities. A significant section of the policy will be around the national rules and the local agreed standards. These must be stipulated within the policy, as this will provide clinicians and managers alike with the agreed framework in which to deliver that timely care. This would need to also include the clock starts and clock stop rules and processes for disengagement and discharge. As well as the national standards, there will be locally agreed service level standards that support referral to treatment pathways, and therefore there should be a section in the policy that includes the organisation's business processes and timeframes. So, for example, where there are clearly defined time standards between referral receipt and registration, triage and first appointment, and expected pathway milestones. The referral management process should also include detail on prioritisation and acceptance of referrals, so it's really clear, not just for staff delivering and reporting, but also clear for other stakeholders reading the policy. There needs to be clear definitions around do not attend, and how these are reported should also be included. So, for example, not all non-attendances would be formally reported as DNAs. So, for example, prior notice patient cancellations and patient choice. Therefore, clear description of reporting and monitoring procedures here is critically important. Detail of chronological booking of appointments is an essential element that needs to be included. So, for example, guidance and detail describing how people with the same clinical priority should be treated in date order, as well as stipulating the national waiting time standards, such as those for talking therapies or early intervention in psychosis, for example. There are some patient groups, known as patient primacy, that will have priority for assessment in line with agreed quality standards. So examples of this would be for veterans, looked after children, perinatal mental health. So the policy must be clear on these and the time standards that apply for each. Pathway milestones. So what do we mean by this? So there will need to be a section where it gives a broad outline of the standardised evidence-based management plan of a sequence of clinical interventions and timeframes, milestones and expected outcomes, because it can be helpful to provide a high-level visual summary of the key milestones on the patient pathway. Now, not everything can be in the access policy in terms of the business and operational processes. Therefore, there needs to be sort of clear reference to any of your standard operating procedures, also known as SOPs, at system, organisational and team level. And examples of these could be SOPs around recording referrals, bookings and rescheduling of appointments. Next slide, please. So thinking about what some of the critical factors could be that contribute to making a good access policy. These could be seen in terms of the information provided in the policy, the behaviours in which we actualise the policy, and the principles in which we drive the need. So in summary, there may be a few questions you may want to consider. Is there a shared understanding? So has or is your access policy being developed with key stakeholders? If the fundamental purpose of an access policy is to ensure patients receive timely, equitable access to treatment in line with the National Access Standards and the NHS Constitution, does the policy stipulate how care is provided equitably and fairly, thus providing staff the guidance and the opportunity to understand the rules and their application? Is the policy clear in what it's trying to do? The access policy should be clear and unambiguous and provide guidance for all staff on the journey from patients entering service to being discharged. It's therefore really important that the wording of the policy focuses on treating patients as soon as possible and in priority order whilst fully respecting patient choice of time and place of treatment. Has a communication approach been considered? So, for example, is the policy's presence and purpose communicated widely? Do all who need to know about it know where it can be accessed and what its core purpose is? Does it provide that framework? So the policy needs to provide a pragmatic framework and give links to those connected standing operating procedures, as this will support staff in being able to deliver timely care in line with those constitutional and waiting standards. How effective is your policy in actualising improved access and flow? Often the litmus test here is in the measurement of how useful and usable a policy is, and this becomes evident in the review process. Therefore, asking staff and other stakeholders whether they find the policy guidance helpful as part of the review, and also providing measurement against these key indicators, will be critical elements. Next slide, which I do believe is another Menti question. Okay, so this is a Menti question. So what do you feel will be the biggest gap for your organisation in terms of these critical factors? You can see that there's multiple choices and you can pick more than one option. Okay, so it is user-friendly and it supports timely and good quality care. It is developed collaboratively, yep. And it's seen as a live document. I think that's absolutely critically important, because a dry document sitting on a shelf is no good to nobody, really, and often can be seen as a hindrance. So it needs to be actualised. Provision of guidance that is clear and easy to understand. We've got 10 here for communication, knowing about the access policy and how it helps. This is great. Thank you, everybody. A real good mix, actually. So I think what we're getting from that is actually all these factors are critically important. Next slide, please. Okay, so ideally, the access policy should be developed collaboratively. Now, whilst access policies are often seen as the business of provider organisations only, we would strongly promote a collective approach to developing a policy, as it requires that joined-up perspective from all stakeholders, including patients and carers. The reason being is obviously different stakeholders will bring different perspectives, and it's important for those different lenses to be represented within the policy around access. There may also be a number of system considerations to think about when writing your own policy. Therefore, oversight of the policy at a system level could be important to ensure it meets the needs of the local community and population served. In order to support strategic thinking and the development of a collaborative approach, it is suggested that the process is led and coordinated by a provider lead that has reach into the wider system, as this will maximise the development and the collaboration required. The policy is also likely to be organisational wide, i.e. an overarching policy, and therefore needs to be sensitive to meeting the needs of different teams and services within the whole organisation. So, for example, it needs to sort of be representative across services such as children and young people's mental health, adult mental health, learning disability, and all those sort of community pathways. Next slide, please. So in order for the policy to be actualised, it's recognised that there needs to be an understanding of access and service delivery across all levels of the system, from those referring into the service, so for example GPs, service users, voluntary sector organisations, those delivering the service, so clinicians, administrators, operational managers, users of the service, and those with oversight responsibilities of the service, so for example boards, CCGs, ICBs. However, not all stakeholders and users will need to be conversant with the full access policy, and therefore consideration needs to be given to the stakeholder needs in adapting the view of the policy depending on what that need is. And you'll see here there's just a bit of a visualisation of what that might look like. So I'm now going to hand over to Louise, who can just give a user experience really of how working and understanding need across systems can support increase to community access. And she's going to use a children and young people's service example. Thanks, Louise.
Thank you, Sarah. So good morning, everyone. My name's Louise Thomas. I'm an improvement advisor within the system intensive support team. The example I'm giving is from my previous role as a clinical network programme manager in the North West Coast. We're going back to pre-COVID and we're looking specifically at Knowsley. Knowsley is one of the most deprived boroughs in the country. It had, at the time that the work was undertaken, it had one of the lowest CYP access rates in the country when we were looking and using MHSDS, and we knew that that wasn't quite true. And so we did some deep dive work. We worked with the intensive support team at the time and undertook a diagnostic review to really understand what was happening and why those figures were really quite low. What we were able to do with that is we were able to map the pathway. We worked with our system partners, particularly our local authority colleagues, and identified that we'd commissioned services, but they weren't jointly commissioned. So local authority had commissioned Cooth, and the CCG at the time had commissioned, obviously, the mental health provider. When we started to unpick all of that with the data, we could see that a lot of the activity wasn't flowing into MHSDS. And that was because of that disjointed commissioning sort of approach. So the way that we tackled these issues was we set up a strategic oversight group. We worked with our local system partners. We looked at the pathways, we looked at those gaps, and then we worked and applied them against the Thrive model. From all of that work, what we could see once we started getting all the access data flowing and meeting the needs of those children and young people in Knowsley is that the access figures increased. We could see that, you know, we did have our children and young people accessing those services, and we could then see that those access figures were increasing. The key thing that we did was around that strong partnership, that we had that buy-in across the patch, and that we had that accountability and effective sort of oversight of the data, and we made sure that, you know, we could see that on a regular basis, and we could address any issues that came from that piece of work. I'm going to now move us on, and we've got a couple of Menti questions now. So the first one is who do you think should be involved in developing an overarching access policy? So this is multiple choice, and I'm going to put 30 seconds on the clock. So do you think it should be clinicians that are involved, operational managers, patient carer reps, your local authority, social care, education, public health, any other colleagues? So we've got, I mean, a really good range. You know, it should from operational managers, clinicians, commissioners, our local authority colleagues. So that's really good to see. So thank you very much for that. I would be really interested in those that have answered other. If you could maybe put a comment in the chat as to what other partners you've worked with in developing that access policy to help us with future events. So the next Menti question, just trying to move the slides, is what do you think will be the biggest challenge in developing an effective overarching access policy? And this is based on your work and your local area. So this is, again, is a word cloud. So you have a choice of 3. So yeah, engagement time. We do know how things are in systems at the moment. No waiting time standards. I mean, the key there is, you know, if you have no waiting time standards, you can develop locally agreed waiting time standards for the services. No appetite, clinical pressures, getting that consensus, yeah. Organisational, and we know there's lots of organisational change happening across the country, and that will naturally impact on these sort of areas of work. Your trust covers a lot, yeah. I mean, these are all really good comments, and what we will do with these comments is we'll take them into our work and into the next sort of phases of our programme for the second season. So time and capacity and engagement are the biggest key areas for that word cloud. So thank you very much. I'm going to close that vote. And I'm going to hand over to my colleague Caroline now.
Thank you, Louise. My name is Caroline Attard, and I'm a mental health mental health nurse by background. So I'm going to talk about the measuring and monitoring purpose of doing an access policy, and build a little bit around what Sarah had been talking about, and also Matt and Sean in the data section. So next slide, please. So to start with, we all know that measuring and monitoring is important, and the aspect of the access policy monitoring is important to actually see if there is any progress or decline, and to provide that framework of continuous improvement that we're all seeking. If we don't obviously measure, it's quite difficult to know if a change has occurred. Also, as we heard so far, doing an access policy requires a lot of commitment from the organization and individuals. So actually committing to it by measuring it is really good. You also detect underlying causes of why it's not successful by measuring. There's a high proportion of improving patient care and experience and outcomes by doing that. And staff experience. But also, as we heard so far, there's a potential reduction of potential harm that could happen by not doing it, and measuring it is really important. Sustaining any improvement that one does as well is really key to this. Next slide, please. So in terms of, as Sarah has mentioned, it's really important to put a focus really on the importance of having good governance and line of sight when it comes to access policies. And this is a slide that we've used in a lot of other modules, because we believe that the governance aspect of how improvement is made is key really. So if you look at the information flow of how an access policy not only is developed, but then measured and then showed kind of the impact, you can see on the right-hand side of the slide that it's across the organization. So it's where the work happens at a team level and in supervision, going all the way up to team huddles, service governance meeting, locality governance meeting, at a strategic level, at an exec level, and also beyond at an ICB level. So when it comes to data, as we said already, it's really important to have a clear definition of how data is aggregated, but also reported at each level. It's also really important to have very clear accountabilities as to who is doing what, who's collecting what, again, at each level. Having a clear understanding of risks or barriers related to it, and having clear escalation as to how not only the information flow is going up and down the organization, but also any other issues related to it, to try and do the golden thread that we're all trying to seek and do at all level of the organization. And having a standardized way of reporting too, as we said earlier. So we have a self-assessment checklist on our Future NHS page that can really help with this, because it breaks it down and is really helpful. So we encourage you to have a look at it. Next slide, please. So how do we measure the impact of the access policy? So some practical step is identifying inequalities and groups required more targeting interventions from existing data, as we showed you earlier, but also from work with communities. Designing interventions and new ways of doing things to meet the need of specific groups. Also formulating plans and setting out key priorities. Delivering the intervention by first creating the strategy, so developing the access policy, but then having a clear way of deploying it. And finally, evaluating from data and feedback what you're collecting. So I almost like to see this as a big plan, do, study, act. You're planning your work, you're doing it, you're studying it, and you're evaluating it. Next step, please. So as we said, key steps are for measuring are identifying where the monitoring is needed, how it's going to be used, again, having step-by-step of each process, and also looking at almost like confirming each process, why there are barriers, why it's not working, why it is working maybe, and having very clear ways of collecting and escalating issues if they arise. Thank you. I think that is the last slide from me, so I'll pass you over to Sarah. Oh no, last slide from me before I pass you to Sarah, which is how would we know that what we're doing is a success? And we've put the jigsaw back in because, of course, we established that these are how it would look good, how an access policy would be good is with these parts of the jigsaw. So, of course, measuring each element of it would be good. Thank you.
Thank you, Caroline. So this is our final section, and it's a short section, and it's just here really to introduce you to the sort of tools and support for when you're sort of developing your own policies. Next slide, please. So you can see here we've developed an access policy checklist tool, and this enables providers to take a step-by-step approach to ensuring key critical components are included when developing your own access policy. We very much see this as being used during the development rather than retrospectively. The tool has been created to support organisations to provide a structured approach that will hopefully support equitable access for all elective services across the mental health spectrum. It's definitely designed to provide information to aid improvement activity, and in the future we would like to develop further tools. So for example, what we'd really like to do is develop a model access policy resource which would provide more explicit guidance. So a bit of a plea here, any volunteers that would like to be involved in that, please do either put your hands up today or drop us a line. That would be amazing. Thank you. Next slide, please. So the checklist tool has it's very much been in the testing phase, and we always welcome feedback on if the tools we create are useful, or if indeed we can further improve what we produce. So this slide provides some snippets of feedback from Sussex Partnership Trust, who couldn't actually be with us to talk today, but did provide us some written feedback. And they've recently developed their own policy and used the Access Policy resource to support them in doing so. And you can see that they found the tool useful in terms of the provision of the content and helping them to know where to start, and also to think about how the policy is applied throughout the whole organisation. There's also recognition that the access policies are new and they're quite a new concept within mental health trusts, and that with that they've found that there was great learning actually in having the resources to support them. Some really useful feedback here, I think, is the feedback concerning not seeing an access policy as just a bit of a tick list, but seeing it as something that supports strategy, improvement and change. So that I hope you find really helpful. So just before I move on to the next slide. Okay, so the next couple of slides, it's just a few screenshots of what to expect when viewing our tool, which can be seen on our Futures platform. Next slide, please. A really useful section of the tool is the quick notes section, as it gives detail and information on definition of terms and links to national guidance and rules. And I can see in the chat some people have put in about extra guidance in terms of those patient primacy groups, i.e. looked after children, and there's obviously sort of a bit further detail in the elements of patient primacy and quality standards there. Next slide, please. So once the policy is agreed, there are a few steps and considerations that need to be thought of. The policy should be agreed in line with your internal governance arrangements, and as we've heard from Caroline, the governance is critical to the actualisation of the policy. It will need to be published with thought given to the internal and the external publication. It's important to ensure that there are patient-friendly and accessible versions of the policy, and other considerations to make once the policy has been written will be: have you considered a formal launch with the comms plan and training sessions that highlights its purpose, importance, and any differences to how guidance was provided before that you had this policy? Communicate the policy across the local health community. So, for example, sharing those usable versions with your key stakeholders so everybody's got those key lenses that we talked about earlier on. Giving some thought about developing those standard operating procedures, or SOPs. So do you have all the SOPs needed to support the implementation? For example, SOPs around appointments, admission offers, do not attend, cancellation management, patient tracking lists, for example. And is there opportunity to introduce the policy and its purpose as part of your trust induction programme to really drive home the importance of effective waiting time and pathway management and its relationship to maintaining high quality of care? And is there consideration about what training, competency and development needs there are for staff to deliver the operational activities described in the access policy? So, for example, and in training needs around sort of management of waiting lists, actualisation of booking procedures. And finally, and it is finally, and this might seem quite obvious, but it's to ensure that there is a regular review cycle in place, ensuring this is underpinned by baseline measurement. So that brings us to the end of the actual webinar. I'm going to hand over now for the very important Q&A section that Frances is going to lead, and just thank you very much for your time. Over to you, Frances.
Thank you, Sarah. Thank you to all the speakers, and thank you most importantly to all of you for staying. And I hope that you've really you've heard some insights and useful things about how to get started on your access policy. Next slide, please. So Michael, my colleague, started the top of the hour by mentioning that, we are in the habit of trying to improve these webinar series, the last of which is coming up in 3 weeks. And so we do need your feedback, as we can't improve by ourselves. And we have an evaluation survey form, which you can access using either the QR code there or the link over there. And those links work, and it all works, and it only takes 90 seconds. So please get going on that while I sort of close out and introduce the Q&A section. So I failed miserably to introduce myself properly. My name is Frances Ibonwoke. I've been part of the team for 6 years, and it's been quite a wonderful journey. And I hope that you can come on board and work with us in some of these projects, these series that we have outlined in the last few weeks. So next slide, please. Great. So the whole webinar series, as well as the associated tools, are available on our future NHS platform. So all you need to do is register, and it's all there. In addition to that, we are offering free bespoke coaching and consultation support to all systems, and there's no criteria associated with it. All you need to do is to be in position, really, to take on the improvement project. And from our experience in working with organizations for a good sort of 6 years, working with systems and individual organizations, there are a few things that are good predictors, if you like, for your project actually being delivered and going well. And these are such as accountable leadership, having good governance in place, and on the subject of leadership that has headroom to be able to sort of spearhead and overcome the day-to-day barriers in moving the project forward. Good reporting routes, as I talked about. Definitely the whole exercise being underpinned by a good implementation plan, and we can support with that. And definitely we have an eye out on sustainability and making sure that we hold the gains of any improvement that is made. And so we very much major on looking at sustainable factors, assessing these through the sustainability assessment. Many of you would have heard of the NHS Sustainability Guide, so we definitely explore those, and we'll do so with you. Next slide, please. Excellent. So we have leads, regional leads in our team that link in with, depending on where you are in the regions, we can link in with you. So if you have, if you want to take any project forward, such as a project in developing your access policy, or indeed any of the other projects that we have talked about, any of the modules we've talked about in the past few weeks, do get in contact depending on your geographical area, and we'll be very happy to support you with that. We've got our team biographies also up on our Future NHS, so you can begin to get to know us a little bit better.